Hello, dear students. Today we continue the set of lectures about neoplasia, and today will be again a pathological anatomy lecture about morphology of neoplasia. And also in this lecture we'll touch the question about, we'll continue the question um, um, about statistics of this cancer, statistics of neoplasia in different countries, and what causes this, etiology of this. We'll discuss a very superficial etiology of this disease because it's a very deep down molecular biology, and every new year, so we find some new information about it, some new information about causes of cancer or any other benign or malignant tumors. But we need to see epidemiology of these tumors. So how they are made, how these tumors are, where we have, in which countries we have different tumors, and of course we also discuss what is a metastasia, what is metastasis. What are metastases, and because it's a main dangerous feature of malignant neoplasia, which causes the death. Okay, characteristics of benign malignant neoplasia. So I remind you, we discussed it in the last lecture, but that's I repeated some things we didn't. I was hurry at that time. Okay. You see, characteristic of benign malignant tumor. When we differentiate benign malignant tumor, we use terms differentiation and anaplasia, and between them is the term dysplasia. Okay, once again, I repeat you, what is differentiation? So you see, it's well differentiated cells. There are cells which resemble the normal cell mass. If you can distinguish this mass from normal in histological view, but on anatomy view, so you see it's in abnormal site. For example, lipoma. Yeah, so for example, you have lipoma. Lipoma is a tumor of fat tissue. These fat cells, which are present, which are normally present, for example, in hypodermis, might be located somewhere in, I don't know, on the surface of serosa cavity. But in histological view, it will be absolutely normal. So no attempts to become cancer cell, but it is a tumor. Anyway, it's tumor. So when a normal when in histological view you cannot recognize it against so cells are normal in this position, but they are grown in opposite way. So here you see this example. The best example is leiomyoma of uterus, and I pointed your attention. So you see it's smooth muscle, so normal spindle-shaped cells, with actin myosin inside. Due to this, it possesses eosinophilic color, yeah, and it has no striations because it's smooth muscles. And you can say, okay, it's leiomyoma, it's benign, it's benign tumor. Also here, benign tumor, I said it in the last class. So benign tumor of thyroid gland. So you see, cells are normal and they keep structure. Yeah, morphologically, so in gross anatomy, we see that it's enlarged. It is it has some specific nodes, so which are very looks very abnormal. So from gross anatomy view, but in histologic view, we see, oh, it's normal. It's normal, and so might be little lesions are present, but they are not so severe to claim that it might be injurious. Okay, and then let's talk about cell carcinoma. So squamous cell carcinoma. So don't watch to name of carcinoma. Carcinoma is okay. It's a well differentiated cell, squamous cell carcinoma. So it's named this carcinoma because it might be dangerous, might cause some metastasia. But it's here on this diagram, it's present in situ. So it's carcinoma in situ, so which is not spreading downward. And what we see here, the cells are present, so it's almost impossible to differentiate it from normal cells. Almost impossible. But here you see they provide the same function but in abnormal place, and they promote the formation of keratin. So cells of it's, you remember, stratified squamous keratinized epithelia, and but this stratified squamous keratinized epithelia must go so step by step from the first layer to second to third to fourth to fifth layer. And the fifth layer is a keratinous layer, yeah, of skin. We discussed it in histology. But here you see it doesn't have this line-like striation, and the stratification is dumped, and that's why keratinized cells appeared in the depth of these epithelial cells. So you see it's abnormal, but still cells are differentiated. Cells are distinctable between each other, and features of epithelial cells are saved. That's why it's named as well differentiated. And usually most malignant cells they undergo the process for which is known dysplasia and then anaplasia. So once again, anaplasia, it's when nucleus is in abnormal shape. Anaplasia, first of all, a variation of cell size. First of all, cell size is very different. Nucleus, the cell division is also not controlled well, and that's why we can see so very large nucleuses, very huge nucleuses, and very small nucleuses. So 1 minute. Okay, and very large nucleuses and very small nucleuses, and also we can see that tripolar spindle. So as on this diagram we see tripolar spindle. It's a mitosis. It's abnormal mitotic figures. So you see, it's instead of normal mitosis in so from 46 chromosomes, it forms two 46 chromosome number cells. But here it can produce absolutely different cells, and this feature is very important for malignant tumors. You see, you remember that from the first lectures, so from the very first lecture in the semester, that genes are maintained by normal. So during the division, so we have to produce normal amount of genes. Normal amount of chromosomes are distributed to each of side. But if some injury happens in these genes, so cells can be destroyed by themselves. We have mechanisms to kill themselves. It's like apoptosis. But also we have another. But sometimes when this mechanism of apoptosis is also compromised, so these cells are able to uncontrollable division, and this uncontrollable division can cause genetic changes. It doesn't care about telomeres. It doesn't care about any other rules of cell division. And they can divide it absolutely differently, and they can undergo endomitosis. That's why very large nucleuses are formed. They can undergo wrong mitosis. Yeah. So this mitosis by which produce not so distribution of chromosomes is not 46 to 46, might be 59 to I don't know. So okay, pairs of chromosomes. So it will be trisomias on different chromosomes. It will be polysomia, polyploidia might happen in these cells. And due to this, some changes in genetic code will be there. And here we have evolution process. So I heard that a lot of people all over the world they don't believe in evolution. They said that, oh, evolution it's just how just fairy tales of scientists. But here we see this. Here we observe this. We have clinical studies about evolutionary process inside our malignant tumor. Evolutionary process. So what is the main feature of evolution here? Some cells which have normal genetic code, so which have more successful genetic code, which shares its genes all over them, shares their genes to produce more cells, they will survive. But those cells whose genes are not very outstanding, so not very cannot survive, yeah, so which cannot be spread in population, so they just died. And here we see the same. Here we see the same that a lot of the cells will die because they are their genetic code is unable to foretell the vision. Unable, yeah. For example, during this mitosis, yes, this wrong type of mitosis, some cells won't get some very important chromosome to the cell, But anyway, so the same cell, but other cell which gain more genes can survive and can produce more successful outspring, and it will be more aggressive, and every cell is more aggressive. That's why cancer should be treated in very beginning. So because every cell division of malignant tumor is more dangerous, even more dangerous than a normal cell division in our body. So every cell division is dangerous. Every cell division so contributes to some changes. But in cancer cells, every cell division produces more mutations. And actually, here, just running over the topic, I can say that because of it, inside the tumors, we have a lot of necrosis process. Necrotizing process is very abundant in a site of necrosis, and due to this, we have two features. First of all, it leads to acute and chronic inflammatory reaction. So first of all, usually we will see the chronic inflammatory reaction. It will follow with infiltration with lymphocytes. Secondly, it causes the activation of node-like receptors inside the macrophages and other cells. And it promotes the synthesis of tumor necrosis factors and interleukin 1, even interleukin 6 sometimes. So in here we see, without infection, produced cytokines and chemokines actually, which promote the inflammatory reaction. And we can see the fever, we can see effects of fever, we can see effects of so a generalized inflammatory reaction and something which resembles the infection reaction, but actually it is a malignant tumor. So that's why never exclude this option from your diagnostic methods. So if you're just keep in mind, it's possible, it's always possible that cancer is there. Okay. So this is yeah. And which features of tumor cells you have to keep in mind? Pleomorphism. It's a variation in cell size and shape. So this is pleomorphism. So normally, so cells are similar to each other. Yeah. So they have very little changes inside it. So usually it has no. They are not giant. They're giant cells. So one nucleus is larger than other nucleuses, as we discussed. Sure, it's pleomorphism. Then abnormal nuclear morphology. So we discussed it. It's normal. So it has disproportionately. Usually they have disproportionately large nucleus. Disproportionately large nucleus. So it necessary for it because of cell division. So we have a lot of cytokinesis. Yeah, and more nucleuses are formed, and we have no interface. So interface is very low, and because interface is very shrinked, so it has a very decreased ability for um, decreased ability to maintain the cytoplasm level. Okay, wait a bit. So. And you see, because of cytokinesis, so cytoplasm amount is decreased. Yeah, so because it splits after the cytokinesis, and but nucleus size must be normal. Yeah, must be normal, yeah, because if it's usually when nucleus is very shrinked, it can die. So. But another so related problem happens here. So it's, you remember, Warburg effect. Yeah, we little discussed about this in with you in first classes. Who's typing me all the time? 1 minute. So nuclear shape is a variable and often irregular, and the chromatin is yeah, I said about Warburg effect. So yeah, I forgot because of Hamad. So Warburg effect is a process. Warburg effect is a process when mitochondria doesn't is not producing ATP, but it's more responsible to produce some amino acids or carbohydrates. And due to this, they are able to produce more substances for cell division. That's a Warburg effect. Another effect which is found, it's usually tumor tissues are well vascularized. It has a lot of blood vessels, and these blood vessels can nourish this tissue very well. And I remind you, so it can be promoted by secreted VEGF, vascular endothelial growth factor. Vascular endothelial growth factor, which is normally produced by macrophages in attempts at healing under the influence of interleukin 4. But here, some of them are they studied how to stimulate blood formation, blood vessel formation inside the tumor, and it takes enough supplement to the site of inflammation. Okay. Um, Okay, and also mitosis. So abnormal figures, mitosis figures. Mitotic figures or typical bizarre mitotic figures are present. So and okay, best example is shown here. So I don't know what they try to show here, but actually much better seen here. So this mitotic figures, abnormal mitotic figures are formed. Then loss of polarity, I said, yeah. So in case of epithelial tissue, so in epithelial tissue we usually have polarity, and due to this polarity, and polarity defines the normal differentiation of the cell. But when differentiation is lost, so it's a sign that it is anaplastic. And other changes, so it depends on site of location. And also, I want to remind you, metaplasia, dysplasia, and carcinoma in situ. Metaplasia. So metaplasia we discussed in that topic. So here we have a typical example is Barrett's esophagus. Barrett's esophagus is formed due to gastroesophageal reflux, and gastroesophageal reflux. I remind you, it's when flux of gastric consistence, so this acid of gastric in the stomach, so enters into the esophagus. So just because of different cases, actually we have so it's a gastroesophageal, so very common disease. So in clinics they will explain you the causes of it. Usually it's congenital, and due to this esophagus, so you remember that squamous cells, they're very helpful in certified squamous epithelium, very helpful against some frictions. Yeah, so they save our tissues from frictions. But columnar epithelia of the stomach, they're helpful against chemical agents. Yeah, and that's why our body has this feature to change the type of epithelium. When change the type of epithelium when we have another stress, and under the chemical influence, under the acidic environment which reflects into the esophagus, it causes the changes of simple stratified squamous epithelium inside the esophagus into the columnar epithelia, and but these changes are affecting differentiation. Yeah, and every time we affect the differentiation, it's a risk of tumor, and that's why metaplasia. So metaplasia is very so this Barrett's esophagus. So where is it name? Barrett esophagus. It's uh, and this glandular epithelia, which appeared instead of stratified squamous epithelia, is able to proliferate much faster than normal glandular epithelia, and it causes the it might cause, AZY Barrett's esophagus is a typical pre-cancer disease. Pre-cancer disease, because next step after this is, after metaplasia, we have dysplasia, and then it causes adenocarcinoma. Okay, the same thing is about smokers. So how smoking causing the cancer? Usually, no one think about it. No one really understand it. So you just remember it like a prayer. Yes, smoking causes a cancer, but how it causes? It must be also explained to you. So because a lot of confusions happened, and actually, so smoking is bad, but obesity is okay. Yes, so sometimes they said, yeah. What should I say? Uh, in the respiratory tract, we have opposite situation. We have pseudostratified ciliated epithelia in respiratory tract. Yeah, and you remember that this pseudostratified ciliated epithelia is able to remove the mucus from the deepness of bronchi and trachea, and it's known as ciliar. So 1 minute. So please sound off, everyone sound off. It's known as mucociliary clearance. Who is nice? It's known as mucociliary clearance. And this mucociliary clearance so allows to remove the mucus from our lungs. And but when you smoke, you irritate this epithelia with dust or with a smoke, yeah. And our body is not very intelligent, yeah. And our body decides it's okay if it's irritated, so must be it's physical irritation. And if we have physical irritation, so it changes the pseudostratified ciliated epithelia into stratified squamous epithelia. And of course, stratified squamous epithelia possess no cilia. And the cilia are atrophied. Of course, stratified squamous epithelia cannot have any kind of cilia on the surface. And of course, mucociliary clearance is dumped in some areas of respiratory tract. And of course, in these patients, all the mucus which is produced, so is not returned to it. It's not can be coughed out, yeah, but it's remained inside the lungs, and it causes the first of all, it causes the obstructive disease, yeah, obstructive pulmonary disease, and this obstructive pulmonary disease, so it's dangerous disease itself, yeah, but in other way. So this metaplasia of respiratory tract epithelium so also can cause a dysplasia later. So same as Barrett's esophagus, and can cause cancer in this area. So it will be squamous cell carcinoma. So usually squamous cell carcinoma is related to smokers. We have adenocarcinoma, which is not related to smoking, which is yeah, it is related, but not so hard related to smoking. But if we talk about squamous cell carcinoma, it is almost always related to smokers. So that's why you can't claim that smoking is not dangerous for cancer. Okay, dysplasia. Dysplasia, as I said, it's disordered growth. So so all these changes we discussed before, this loss of polarity, abnormal mitosis, yeah. What else we discussed? We discussed abnormal nuclear morphology, pleomorphism. All of these are included in a term of dysplasia. So but it has different levels of dysplasia. Yeah, I said we have differentiation and anaplasia, and dysplasia is like a middle stage between anaplasia and differentiation. We can in dysplastic cells we can understand which cell is which function, but in dysplastic cells they have some stranges in information. So dysplasia for different tissues is different. In different tissues, it's explained in different way. That's why it's better to discuss it in pathology, not in general pathology, in a systemic pathology topic. But anyway, so you remember dysplasia, it's a middle between malignant, so differentiated, and aplastic tumors. And then carcinoma in situ. So what is carcinoma in situ? Carcinoma in situ is when cells are it's when tumor it has attempts to be cancerous, and by the experience of doctors, when we see these cells, we can say, oh, it very soon become malignant, it very soon become metastatic, but now it's very small, and we can remove it without consequences. Yeah. And so I said about it in last lecture, so that way let's continue. Okay, and dysplasia usually is precursor of malignant growth. So here you see it's carcinoma in situ. So this is typical appearance of carcinoma in situ, squamous cell in situ. So you see it's abnormal certified squamous epithelia. Normal certified squamous epithelia possess absolutely different appearance. So nucleus are much smaller, yeah, and between cells we have some gaps, yeah. So it's normal, and these cells. But here you see they are very rapidly dividing cells and very dense space between the cells, but basement membrane is still intact. Cells are not spending, so they are not sharing down. They don't penetrate the basement membrane. And pay attention to these things. So you see these small cells. What are these small cells? They are immunity cells, lymphocytes. Usually lymphocytes are present there. It's because the cells, as I said, any malignant cells, they have a lot of evolutionary process, and in every evolution, we have some cells which are not survived. We have a lot of species which are not survived. Yeah, and these not survived cells, they must be removed and must be digested by macrophages or neutrophils or something like this. And for this we require immunity reaction here, and usually it's chronic inflammation. And here in the high power, so what we see here, there are mitosis. So as we discussed in histology, so in stratified squamous epithelia, in upper parts of stratified squamous epithelia, mitosis are very rare. Mitosis are very rare because less nourishment comes, and genetic predisposition says to us if we have less blood intake, so we shouldn't divide. But here we see mitosis. Yeah, so this typical metaphasial plate is visible here. Also metaphasial plate is present here. And this is prophase only starts. So also here also might be prophase or already metaphase starts. So you see it is a process. It is a process of carcinoma in situ. So this is carcinoma in situ. Okay, let's talk about local invasion. That's a new for you. Local invasion, so it's very important for clinicists. What is local invasion? Local invasion when metastases are formed. Metastasis, it's like metastasis in the same tissue when it's located. So just imagine then in this diagram, yeah. So here you see the basement membrane, but when you lost the basement membrane and when some part of these cells, same cells, but appeared downstream here, you can say it's invasion, local invasion. And this invasion, it's in progress. It will cause the metastasis, and this type of cells will be present not only in local site but all over the body. And now, so on this level of medicine, on nowadays level of medicine, we almost cannot treat metastasis of tumors. And if we have abundant metastasis all over the body, so we almost always say that it's untreatable, and we can give only poor prognosis to patients. But local invasion, let's talk about local invasion. Local invasion is present only underlying tissue. If we talk about epithelial cells, it is local invasion is happen under the basement membrane. So take a look on. Yeah, it's metastasis. Mm, okay, in practical class I'll show you the local invasion. So, but it's I think you already understand it. Next to the development of metastasis, invasiveness is the most reliable discriminator of malignant and benign tumors. Look, this invasion, why it's important for clinicists? Yeah, so local invasion is important to say that is this tumor already attempting to spread. And you remember that under the epithelial cell layer, we usually have loose connective tissue, and in loose connective tissue we have lymphatic capillaries, blind-ended lymphatic capillaries, and these cells which are invading in this loose connective tissue, they can detach from the surface of this tumor and travel through the lymphatic system, or even they can invade the blood vessels and travel through the blood vessel. So you see, it's very dangerous situation, and it's a last step before metastasis. Okay, and what is a metastasis? Metastasis, it's defined as a spread of a tumor to sites that are physically continuous with a primary tumor, and an event that in a unequivocally marks a tumor as malignant. Unequivocally. Unequivocally. Okay, so that's if we have spreading of this, if we have metastasis, so we can claim it is malignant. Okay, okay, and this okay, how it spreads. So we have to discuss pathways of spreading of this. Pathways of spread. It might be direct seeding to of body cavities or surfaces, might be lymphatic spread, and hematogenous spread. Let's talk about direct seeding of body cavities or surfaces. So take a look. So this is omentum by metastatic ovarian carcinoma. So here it's shown like ovarian. So you remember location of ovarium. It's present in peritoneal cavity. Yeah, so it's almost present in peritoneal cavity. And tumor of this will spread along the peritoneal cavity and might sit on the surface of omentum bursa. And then it invades into the omentum bursa. That's it. So nothing tough in it. And actually, example, so from my clinical practice, I knew the patient who had tumor in endometrium tumor, and she was recommended to have a surgery, and then she had a surgery, and but after the surgery, these tumors appeared in peritoneal cavity. So that's why what's my message here? So that's pathway. So spreading by body cavities or surfaces is also possible for after the surgery, and you have to treat this tumor like bacterial seeds. Yeah, so you have to wash it out. So you have to prevent seeding of these cells in any other organ. Yeah, because it can spread in other organ too, not only in the organ of origination. And when you do the surgery about malignant tumor, you have to care about cells where they are attached to. Okay, and they can spread directly to the other organs. It is local metastasing. It happens when a tumor appears in one organ, and then it invades not only connective tissue under this organ, but already another organ. For example, another example from my practice, it's prostate cancer. Prostate cancer, and when it's evade, when it's evade the surrounding connective tissue, it's not metastasis. It's just invasion. But when it penetrates into the rectum, it is a metastasis. It is a metastasis, and of course, it is treated in absolutely different way. Okay, and then another wide way of spreading is lymphatic spread. I already said about this a little bit. So under every epithelia, we have loose connective tissue. And this loose connective tissue is usually accomplished with lymphatic capillaries, with blind and lymphatic capillaries. And these lymphatic vessels, you remember where these lymphatic vessels are travel to? They travel to the lymphatic nodes, lymph nodes. And here on this diagram we see it. This is normal lymph node. So here we see the normal lymph node. It's abnormal already, but it's tissue of lymph node. But if we have, if some cells, abnormal cancer cells, they're spreading, they appear inside the lymph capillaries, and by lymph capillaries it enters into the lymph node. And what happens in lymph node? It's a seeding of lymph nodes happened. Seeding of lymph nodes, and that's and our immunity tries to kill it. Our immunity doesn't allow further spreading of the cells. It causes lymphangitis and lymphadenitis. So you see, it is one of ways of our body to handle this tumor. Just one of the way to keep us alive for a little more time. Because usually the most common way of spreading of tumor is lymphatic pathways. And then lymph nodes, they play a role of like so checkpoints for this tumor, and it postpones the spreading of cancer. Uh, and actually, for we as a practitioners, we use it for detection of cancer metastasis by checking of lymph nodes by thickness, because it always will be inflamed when tumor is invading the lymph node. It always will be lymphadenitis. So it's lymphatic transport. Okay, sentinel lymph node is defined as the first node in the regional lymphatic basin that receives lymph flow from the primary tumor. Okay, that's a sentinel lymph nodes. It will be discussed with you in pathological in oncology. So for every location we have some sentinel lymph nodes. So for example, so just a few examples. Axillary lymph node. So it's usually it's due to so axillary nodes is responsible for upper limb and breast areas, and in these cases, in cases of tumors, malignant tumors, in those locations, it can cause so it will be interrupted in these lymph nodes. Okay, but it's a topic of discussion of localized oncology. Then hematogenous spread. So how tumors are spreading by blood? Easily. Yeah, so just very easily it can spread. So when invasion of so local invasion reach the blood vessels of loose connective tissue under this, it can penetrate the blood vessel, and then a little metastatic thrombi happens. We discussed it in a thrombosis topic, yeah, that in embolus we have metastatic emboli. Metastatic emboli is a part of tissue, part of malignant tissue which appears inside the blood, and this group of cells can stuck in any organ. So if it's very large, it causes a infarction in this area. But when it's very small, so few cells are just spreading by this, not attaching in a huge mass, they can sit inside the organs like liver, for example. And here you see these white patches, they are metastases. And metastases are in liver. So where from metastases of liver come? And here you need to remember the portal vein system. So everything which is so where from portal vein collects the blood, so it might be metastatic pathways of our body. It's, for example, most common metastasis is a colon tumor. Colon tumor shares their metastasis into liver. Okay, And also, but in other locations, in tumors of other locations, so which are out of abdominal region, out of peritoneal region, I mean, which are not involved in portal vein system, they share the metastasis usually in lungs, because you remember circles of circulation, and the same way we have pulmonary embolism. Due to thrombosis. The same way we have pulmonary, so the same way we have metastasis in lungs. So that's why always keep in mind that might be it's not in these locations in liver and lungs. It might be not original location of tumor. It's very commonly it is just metastasis. And actually, how to differentiate metastasis is very easy to differentiate them. Yeah, you see, it's like really seeding of this bacteria, seeding of the cells into the liver-like bacteria. Yeah, and if one colony-forming unit, so when this metastasizing cells appeared here, it starts to invade the entire organ, and everywhere we have just beginning of the seed. So in the middle we have a seed, and it spreads around it in circular way. So you see there will be a lot of seeds in one organ. This typical metastatic appearance. For example, initial tumor of liver would be seen like one tumor in one location, and might be invasion to other parts in a ray way. So like rays, it will spread all over the liver. But here we see it has a lot of seeds. Same to lungs. In lungs, you will see a lot of colonies of metastatic tumors. Okay, here are also example of so benign tumor and malignant tumor. So here it's a benign leiomyoma and malignant leiomyosarcoma. Benign leiomyoma. So you see, small, usually small, but it's wrong. So sometimes it might be very large. So you see, well demarcated. So what's very important? Well demarcated. So it has very well borders. In ultrasound, it's visible. So when it has some spreading around, it's well demarcated, and as well as well demarcated, it's not very injurious, and we can treat it. Yeah, slow growing. So if it's not the first time you give a diagnosis to this patient, you have to check it every half year, or in some cases faster, so frequency is higher. So you have to check the growth of this tumor, and if size is not changing, so yeah, you can claim it's slow growing, and might be it's benign. It's non-invasive, as I said, it's well demarcated and has no invasions like we see here. Non-metastatic, of course, so obviously if it's not non-invasive, it cannot be metastatic, and well differentiated. If we have biopsy of this benign tumor, we see the normal cells, usually normal cells, or little dysplastic cells. But little dysplastic cells, we still understand where this tumor comes from. But in malignant tumor, we have another picture. It's usually large, if we talk about leiomyosarcoma, but tumors, malignant tumors, are not always large. They might be very small also. Okay, poorly demarcated, always present. So poorly demarcated. So here you can hardly see the borders of it, and it hardens the treatment. So that's why surgically we cannot remove this tumor, because if we want to remove it, we need to remove entire uterus. And sometimes we do this. Sometimes we remove entire uterus. But actually, for this poorly demarcation, so how we can treat it? So just a little clinical correlation. So how we can treat the poor demarcation? We have a neoadjuvant therapy. Neoadjuvant therapy, so it's a treatment with chemotherapy for tumors to prevent the spreading of the disease. So we understand that chemotherapy cannot treat entire tumor. It cannot kill entire tumor, but it can kill this metastasis and invasive properties. And then during the surgery, we can remove only this part of tumor, but not the entire organ. So in some cases it's used in this way. Of course, in this case in leiomyosarcoma, so anyway we have to remove the tumor, we have to remove the entire uterus. Okay, so treatment is not my task now. Rapidly growing with hemorrhage and necrosis. Yeah, as I said, tumor cells, they're able for so very abundant growth, very fast growth. And during the rapid growth, so it has a, as I said, process which is known as evolutionary process happens. And due to evolutionary process, a lot of cells died and produced a lot of blood vessels. Yeah, as I said, VEGF produced also, and that's why necrotized cells, some cells can get necrotized, and blood vessels which are present there, they also can leak the blood, and that's why sometimes the first manifestation of tumor is a bleeding from the site of malignancy. So might be you heard about it, because a lot of blood vessels are present in these tumors, and a little injury to this causes the bleeding. Okay, hemorrhage and necrosis happens. Okay, locally invasive. Locally invasive is this invasive structures. You see this invasive sprouts. Is sprout way of growth. That's why it's called as named as cancer. Sometimes it's like crab, yeah, crab-like appearance. And then metastatic. Of course, this local invasion might spread along the veins and can enter into the they can spread into the lungs. Usually tumors, so metastatic tumors, metastasis of genital system tumors, they are going directly to the lungs and poorly differentiated. So in a histological, when we do this histological review, so we can hardly see the normal cells. So we can compare with, here we see normal cells, yeah, but here cells are absolutely abnormal. They have different figures. So their nucleuses are too large. Somewhere their cytoplasm is too small. We have pleomorphism. Yes, this pleomorphism, nuclear changes, mitotic figures, all this, and necrotized cells you see here. So that's a feature of malignant tumor. Okay, that's in general we discussed it about it. So now let's talk about epidemiology of cancer. So very shortly I explain it to you. Epidemiology of cancer. So here in 2019, estimated cancer incidence by site and sex. Okay, you see, melanoma of skin 6%, oropharynx 4%. So this tumors of oropharynx for 4%. Lung and bronchus tumors in males. We're discussing males only. Yeah, it's 13% in general population all over the world. In tumors of pancreas 3%, kidneys 5%, colon and rectum 9%, urinary bladder 7%, prostate 20%. So that's I want to pay your attention. Prostate cancer becomes very common, but why it's incidence, yeah, so which is found, but actually why prostate cancer is so abundant, becomes so abundant. Actually, it's not because prostate cancer is very dangerous. Might be less dangerous than others, but it were not diagnosed before. Prostate cancer is found very rarely. So okay, and but for prostate cancer treatment, we have a diagnostic. So every person, in most of countries we have a procedure. It's a PSA marking. So every male submits a PSA level. So it's prostate specific antigen, which is increased in case of prostate cancer. And we can detect prostate cancer even if it doesn't hurt, doesn't affect the body so yet. And that's why in case of prostate cancer, we can detect it in very early stages, and that's why incidence is very high, but death is very low in relation to you see 20%. of all cancer cases is prostate, and only half of them are mortal. Only half of them, so less than half of them are mortal, because we can detect it earlier. Okay, then urinary bladder, leukemia 4%, non-Hodgkin lymphoma 5%, and all other sites 24%. Okay, in females, what is the most common cancer? Okay, same, approximately, but breast cancer is very common in females, and that's why I already said it to some of you in practical class about yeah, that breast cancer is very common. We found the gene which is responsible for breast cancer and which increase the incidence of breast cancer in females. And if and now we can check the genes in this you can check the genes, and we can remove the breast cancer before we can remove breasts before breast cancer happens. And that's why, and actually diagnostic methods of breast cancer is also improved in last decades. Then breast That's why mortality of breast cancer is decreased 15% only. Okay, kidney cancer, pancreas, same as in males and females. Ovary, uterine corpus. So ovary and uterine corpus are also very common location of tumors, but not so common. Yeah, but anyway, you see mortality of ovarian and uterine corpus are less. So ovarian is more, but uterine corpus less, because ovaries don't hurt, yeah, and it's hard to detect them. Okay, and we have also non-Hodgkin lymphoma and all other sites. It's other sites, of course. So, but what I can say to you, so about oropharynx. Why in females we don't have oropharynx cancer, but in males we have? So answer this question for yourself, or we'll discuss it in practice class. So, and then I want to show you another statistics, another. Okay, let's talk about causes here. So, okay, let's talk about causes. So, what happened to my, yeah. Sorry, my computer so is very slow. So this is incidence of different different cancer incidents. Guys, what happened? Who's talking? Abdul Jalal. Okay, leave the meeting, please. Second time. Okay, then you see, incidence of cancer is much higher in regions in in very rich regions. Yeah, Canada, USA, France, United Kingdom, Germany, Sweden, Norwegia, Finland. Yeah. Hungarian, Austria, Czech Republic, yeah, then Italy, Switzerland, so Australia, of course, New Zealand. You see, and actually, in comparison of North and South Korea, so incidence of cancer is more commonly in South Korea than North Korea. So what it says about? It says, and it doesn't say that we have very bad cancer situation. We have better how it's called. Um, Pollution situation in these countries. No, actually, pollution is much more common in China, also in India. So they are much more abundant in Kyrgyzstan. Yeah, so in these countries, very polluted air. But cancer incidence is much lower than in these countries. So because of what? So actually, it happens because it has much better much better. It happens not because of better statistics, so because of better treatment, because of better we found this cancer better. You see, its incidence is higher, Just in our countries like Pakistan, Kyrgyzstan, Mongolia, yeah, or African states, we don't detect this disease. We don't have so very well aligned oncology statistics. We don't have an oncology service yet, and that's incidence is decreased. So because we don't see it. Okay, let's talk about which is the most common tumors worldwide. Sorry. Okay, take a look on this diagram. So, what is the most common cancer in world in Western world? Western world cancer. Actually, in Africa, it happens. Australia, New Zealand. What's the most common? It's a prostate cancer in males. Prostate cancer in males is the most abundant all over the world. Uh, but in Asia, in our region, so in post-Soviet Union and China region, without Tajikistan, Kyrgyzstan, it's very common lung and bronchus tumor. So what is it related to? It is related to smoking. In these countries, smoking rate is very high, and that's why in these countries, so where we have a lot of smokers, they have they have lung and bronchus tumor. But take a look on India, Pakistan, and Afghanistan. In India, Pakistan, and Afghanistan, we have oral cavity infection. Sorry, infection. I said oral cavity tumors. And what is it related to? Actually, it is related to chewing tobacco. Chewing tobacco, or I don't remember how it's named, but anyway, you have some. It's a specific way of chewing something, yeah. So some students gave it to me so one time to try it, and I spit it out because I cannot do this. I cannot try it. But actually, it causes the oral cavity tumors in males. And you remember the statistics? Yeah, I said you that in males we have 4% all over the world, and especially it's distributed between these countries: India, Pakistan, and Afghanistan. Also, very common in some countries of Africa are common this color, Kaposi sarcoma. What is Kaposi sarcoma? So Kaposi sarcoma appears only related to AIDS. In AIDS, it happens. So HIV virus causes the AIDS, and due to this AIDS, it evolves the Kaposi sarcoma. And in these countries, AIDS is very common, is extremely common, and that's why Kaposi sarcoma is worldwide. Is very common in these countries like Mozambique, Botswana, and Lesotho, Swaziland. These countries are very common. Okay, and other types, so which are present in Iran, it's a stomach cancer, and Turkmenistan, also in Kyrgyzstan and Tajikistan, it's a stomach cancer, very common because of so they relate this with spicy food, but so might be it's all, but it's much more common. So stomach cancer much more common in Pakistan, in India, but anyway. Just because you have in your countries you have more oral cavity tumors, that's why it's overlapping it. But anyway, incidence of stomach cancer in our countries is much less than in your countries. But anyway, it's predominant cancer type. Okay, and also, okay, what else we have? Esophagus cancer. So it's I don't see where we have esophagus cancer. Might be in Bangladesh, yes, so might be Bangladesh esophagus cancer. Okay, and others are not so important. So liver cancer is very uncommon. It's present in a few locations here. Okay, breast cancer. So it's a incidence of breast cancer we discussed. Yeah, so it's about diagnostics, usually related to diagnostic. Okay, what causes the cancer? So which environmental factors are responsible for cancer. Infectious agents. So, for example, so one of virus is totally so we sure that it causes a malignant tumor. It's a human papilloma virus. Human papilloma virus causes the cancer of cervix of uterus. So we sure that it causes. Might be other tumors also have some of these properties, but we don't know it. It's in study process. Smoking. Cigarette smoking causing, we discussed, it's respiratory tract tumors, and we'll discuss about it in less pathophysiology topics. Alcohol consumption. So alcohol consumption, so it's has a very has some increased risk of hepatocellular carcinoma, which is followed after the alcoholic cirrhosis, and might be also it is responsible for oropharynx, larynx, and esophagus tumors sometimes, but it's not so abundant. So it's rare types of tumors. That's why alcohol. So usually alcohol is never named as a carcinogens, but it's just bad habit, yeah, of some person, and just to frighten them, we name it as alcohol is very dangerous for cancer. It's not dangerous for cancer. It's more dangerous for liver than for liver for cirrhosis, alcoholic cirrhosis. But just usually we say that alcohol is very dangerous for cancer too. Okay, diet. So dietary. So we have a lot of different dietary factors, and for example, absence of intake of some compounds cause the different cancers. So it is studied now, and some of these studies show some correlation with dietary and the type of cancer. So especially it's related to food for stomach cancer. Yeah, is spicy food promotes the stomach cancer evolution. So obesity. Obesity. So we have no direct pathophysiology pathway of how obesity promotes the tumors, but we have this directly correlation between obesity and malignant tumors. So they are much more common in obesity people. So must be it has some another relation. Might be obese persons, they don't so attentful for their health, and that's why their cancers are much more mortal than in they have much larger mortality of the tumors than other people. Okay, reproductive history. So especially in female reproductive system, that's so intake of contraceptives or combined oral contraceptives, they can cause the reproductive, they can cause the promotion of tumors and actually less amount of pregnancies. They also culturally, so culturally, that we used to say that, yeah, we don't need to born more and more people. Yeah, so we don't, if you can't afford to feed a lot of children, so don't burn them. Yeah. Okay, but actually, in females who born all over their life, so a lot of children they have much less rate of malignancy in female genital system. So then environmental carcinogens. Environmental carcinogens is ultraviolet. It's arsenic. So it's present in Bangladesh in water. Some medications, for example, methotrexate is a very common changer of DNA, and asbestos. So in work, in some jobs like mine workers, so it can cause asbestosis, and it is a typical carcinogens. And of course, grilled meat, high fat diet, alcohol. So all these things which are usually declined for patients. Okay, That's okay. Today we discussed a lot of important things. I hope you will observe it properly in before the next class. So now I'll check your attendance.
मैं दोबारा क्लास ज्वाइन कर
Okay. So okay, thank you. You can go.
Okay, sir. Thank you.
Bye.